So we have here.
Ma'am, I think you should give her an opportunity to withdraw. Maybe she might consider.
She's not going to withdraw, and we have Dr. Vaishali Suri, the very vibrant neuropathologist from All India Institute of Medical Sciences at New Delhi. She has done extensive work in the field of brain tumors and other aspects of neuropathology, and also has done excellent work in molecular neuropathology. And but she would be talking about, she is the against the
molecular markers in routine reporting of gliomas are necessary, mandatory, unavoidable. We can't do without them. Yes, I am there for demolecularization. Let me see how much I can convince you people for demolecularization. If Modi can do demonetization, Vaishali can do demolecularization. I agree there has been explosion of molecular data since 2007. It has given us lot of detail about tumor initiation, progression, pathways of gliomagenesis, and yes, we are there with our 2016 WHO classification, which says we have to integrate phenotype and genotype, and it has given us promises that it would be accurately, it will give us accurate diagnosis, prognostic information, and it would be useful in therapeutic intervention. But my dear opponent, before you put these markers on a pedestal, we have to, why not? We have to take care of current health situation of our country. Who is going to be the beneficiary? Is it the customer or the industry? What is the cost benefit ratio? Are we ready with our infrastructure? Are we ready with the quality control? What would be the turnaround time? What are the threats? And then only I will conclude. My country is fighting for clean India, houses for all, disease-free India, and toilets for all. And we are on our own tangential path of diagnostic molecular pathology for all. My country has the distinction of winning Oscars for glorifying its poverty. Yeah. My country has the largest number of infants deaths, maternal deaths, tuberculosis cases in the world. My public health system is in disarray. Dear sir, dear Dr. Demling, in a talk at Harvard School of Public Health in 2012, it was noted that India spends only 2,600 rupees per person per year, where you are telling us to get molecules. Whereas in US, it is 5.7 lakhs per person per year. Look at this. We are wanting to, look at the irony, we are wanting to bring molecular markers in a country which cannot afford even branded paracetamol. And who's paying for it? Don't we all know that the most of the research is done by the industry and the results are skewed in favor of a new medication or a molecular marker, and it is the customer who gets screwed. So, are we infrastructure ready? No. Do we have the budget? No. I really wish my opponent was good friends with Jaitley ji and he could get me these two. Then only I would check the credibility. Yes. Okay. So, we have nothing to do with these. We are just going to check the credibility of these markers. Are they really giving us information which is diagnostic, predictive, prognostic? Let us check. So, the markers which we have been listening for years now, which have, come as, will give us prognostic, diagnostic and predictive information are IDH1 mutation, 1p19q loss, ATRX mutation, MDMT methylation in diffuse gliomas, and BRAF fusion and B600E mutation in circumscribed gliomas. So, I will start with the IDH story. It is indeed has been proclaimed to be a very useful diagnostic and a prognostic marker, but it has no role in prediction of therapy. Yes, we have a very robust antibody which has a very good concordance, almost 100% concordance with mutational analysis. But in IDH1 negative cases, you have to do sequencing. So, what is the cost? Who is going to give me equipment worth 2 crores? Each test both IDH1 and IDH2 is going to cost me 2,000 rupees per test. And I'm not talking about infrastructure, sir. And I'm sure in 70% of the cases, I fail to be a pathologist if I cannot diagnose a diffuse astrocytoma, oligodendroglioma, or a pilocytic astrocytoma. Yes, I need this antibody, but I need it only in 20 to 30% of difficult cases, sir. And please look at these two classical oligodendroglioma cases which came to our lab. Dr. Sharma showed me, oh Vaishali, these are both IDH negative, what should we do? Yes, we have that Dianova antibody, sir. It worked well in 1 in 100 dilution. In 4 months, it started working in 1 in 50. Now I have to reduce to 1 in 30. There has been a beautiful study which has done meta-analysis. They have reviewed all major papers since 1990, and they have come to the conclusion that more extensive surgical resection is associated with longer life expectancy even in the current neurosurgical era. And since yesterday, no one has talked about where IDH is located. IDH is good, IDH wild is bad, but don't we know IDH mutated gliomas are located predominantly in the single lobe, frontal, temporal and cerebellum, and they are rarely located in high risk regions. And this paper has shown that their less aggressive behavior is because of their MRI findings and their location. And there is another study from Germany which has analyzed 100 astrocytic tumors, and they have performed IDH1 and IDH2 mutations by direct sequencing, and they have shown by both univariate and multivariate analysis that there was no association between IDH1 mutation status and progression-free survival, time to malignant progression and overall survival. Why are we not showing these studies? We are just showing a beautiful story. And look at this, I was amazed to see that even in IDH mutant cases, it is gross total resection which helps the patient. And the patients which undergo subtotal resection, they don't do that well. So what is the most beautiful prognostic marker? It is the surgeon. So next time, I am going to write in my report that this case is IDH mutant, but kindly correlate with extent of resection. In glioblastomas also, we know that frontal location, extent of surgery, younger age, small tumor size, they all give us information, but we are not ready to know that because molecules are in the air. In glioblastomas also, it has been shown that IDH mutant tumors are not prognostically more favorable than wild type when controlled for location, age and sex. And most of the IDH mutant cases are located in the frontal lobe. And this paper also says that most of the benefit comes from its different location. So we have so many studies which shows that there are validated clinical prognostic markers also which which are available online, and we can correlate the patient's prognosis very well with that. So if I really check IDH, 70% cases I don't know, and where I need it, it won't work. So ultimately I have to consult Dr. Sharma, who is the doyen of diagnostic pathology in our this thing, and I have to agree. So he is better than IDH. So now taking you to the ATRX story, everyone knows it's a very useful diagnostic marker but no role in prognosis and treatment decisions. We have the ATRX antibody, which is a very good surrogate marker for mutation, and loss is a diagnostic hallmark of astrocytic tumors. But ATRX mutation is again seen in 70% of astrocytomas. I do not need ATRX in 70% of my cases. I need it, yes, in 30% of my ambiguous cases, the cases which have mixed histology, and there it will cause me problems. I'll have mosaic staining. What do I do? Do I have the option of doing mutation? I'll show you how difficult it is. So we have small tumors with diffusely infiltrating tumors with low tumor volume. We have squeezing artifacts. We have endothelial cells, microglial cells, neurons, and every day I keep on getting calls, madam, what do I do? Half is lost, half is gained. I don't have answers. Can we do Sanger sequencing? No, the gene is so big. You don't have any hot spots. The analysis is very, very expensive and tedious. So what am I left with in cases where I needed ATRX? It is not helping me. So if I am beautiful, you are also beautiful. So if histology is beautiful, marker is beautiful, and it is as ugly as histology when you need it. And if I have to resort to targeted sequencing, the cost is very high. Now coming on to the next marker, there has been, this is the god of all markers, 1p19q, diagnostic, prognostic, predictive, everything. Every answer is in 1p19q. You don't need histology of oligodendroglioma. So the method to do it is FISH or PCR. But look at FISH, even Dr. Dembling, sir, you cannot now say no, is afraid of fishing, he told. And I have recorded your statement, sir. There is so much inter-observer, inter-laboratory variability. There are no common standards for, analyzing FISH across laboratories. And it is really, I have been doing FISH myself for past 8 years. It is really difficult assessing FISH in cases which have aneuploidy and polyploidy. There is lack of, consensus. And this, look at this, marked in red. FISH is not 100% criteria for calling someone as having partial or whole arm loss. Yes, we have beautiful data. EORTC and RTOG trials have shown that when we give PCV to anaplastic oligodendrogliomas, 1p19q is, both prognostic marker, both predictive marker. Yes, I agree. But have they studied what is the significant toxic effect of PCV? How many patients did have preserved cognitive function and what was their quality of life when they received? Yes, they lived. How they lived, they only know. When RTOG data was analyzed by histological analysis, please see all the residents. It is only classical oligodendroglial histology which had a very, very good high concordance. So beautiful means beautiful. Concordance with 1p19q, these patients had the longest survival, and in non-classical cases there was only 13% concordance, and these patients had intermediate survival. It is not Vaishali Suri, these are graphs from papers. Okay, so this is not politics. Classical oligodendrogliomas, even without 1p19q deletion, have intermediate overall survival. There is a paper which says that cases which have, ambiguous morphology, like we don't know whether they are oligo or not, if you do FISH as well as LOH, although, in beautiful cases they have beautiful concordance, but in these kind of cases, the disconcordance is 70%. So that means in an atypical case, if I am resorting only to FISH, I am giving a false promise to the patient. And it has also been observed that in cases which have 1p19q loss plus aneuploidy or polysomy, they do not do as well as the cases which have no polysomy. So in the end, what is the winner? If I have classical oligodendroglial histology, you give me the age, the radiology, clinical history, and Dr. Sharma. I don't need anything else. Why I am saying Dr. Sharma, Dr. Sarkar? Because it is the experience of, the histopathologist which is prime, not the molecular markers. Now coming on to MGMT, we all know there was a seminal paper by Heggie et al. Which has shown that patients with MGMT methylated when glioblastomas, they do very well when they are given temozolomide. And it has been proclaimed to be a very good prognostic and a predictive marker. There have been, the literature is flooded with studies. But why? I want to ask, why only few centers have implemented it in routine practice? Because there is, number one, no alternate treatment for the patients who are unmethylated, and number two, there is no consensus till date, which is the most suitable technique. There is intra and interlaboratory variability, and MSP PCR doesn't work well on formalin fixed tissue sections. And, we just don't want to look at the negative side. But anyway, this is my job. I did that. I did the survey, and I saw that there are so many studies which say that overall survival of the patients and their progression-free survival is irrespective of their MGMT status in glioblastomas. And there has been a meta-analysis. I asked this person to give me a whole paper. Abstract is also available online, and in this meta-analysis of 10 eligible studies has shown that progression-free survival is not different in methylated and unmethylated patients. And even if you give dense temozolomide dosage to methylated and unmethylated patients, no benefit. In non-elderly GBMs, MGMT methylation is not, does not fulfill the criteria to be a predictive marker, but there are two trials, NOAA 8 and Nordic trials, which say that MGMT testing should be performed in elderly GBMs. Why? Because patients who have methylated MGMT, they can be given temozolomide alone, they do better, and with unmethylated MGMT can be given hypofractionated radiotherapy. But this study has not given any idea of true predictive value of MGMT promoter methylation in their study. The analytical performance of the test was not investigated, and MGMT status is available only in 50% of the cases in this study. And yes, they have talked about what are the side effects of a patient, 70-year-old patients whom you are giving temozolomide, and they have observed majority of the cases had grade 3 neutropenia and thrombocytopenia and much more. Lot of platforms are there, but no consensus. Pyrosequencing has been now agreed to be a robust, valid and reliable and quick method, works on formalin fixed sections, but there are so many unresolved issues. Since the methylation sites are heterogeneous, we don't know which region would give us a clinical decision making answer. We don't know what are the threshold levels. We don't know how we are going to have different cutoffs for different age, for different performance status, for different radiation dosage. We don't have answers. So there is a lot to be answered before we make MGMT come from bench to bedside. There is a paper which shows that in glioblastomas there is, and we all know that there is lot of intratumoral heterogeneity, not only at transcriptional methylation, also at mutational level, at multiple levels. So this author says that why are we propagating single biopsy in a single patient, and he has saying that in a substantial proportion of cases when they have taken different biopsies, in one biopsy it was methylated, in other biopsies it was unmethylated. And I won't go into details, but there is aberrant expression of other DNA repair mechanisms like mismatch repair system and induction of hypermutated phenotype. That is why, my dear opponent, I told you even if you give me 1 day per marker, it would be less. We have also reviewed MGMT status, reviewed several publications, and we have shown that there are therapy and progression induced changes in the methylation status, and there is induction of hypermutated phenotypes. So that was the story of MGMT. Now coming on to the beautiful BRAF alterations, fusion and mutation. They have the answers to all our agonies. So fusion is seen in majority of pilocytic astrocytomas and V600E in PUXA, in your ganglioglioma and epithelioid GBMs. Again, sir, I don't need this marker in 60 to 70% of my cases. I need clinical history, I need age, I need radiology and good histology slide. I am happy. Why I am happy? Because I am sad when I get these stains and I have to, really resort to again Dr. Sharma. There is a study which has shown that controlling for location, BRAF rearrangements do not have any statistically significant difference in outcome, and extent of resection and age of patient have better answers than BRAF. Again, there have been controversial data regarding prognostic value of BRAF V600D also, but the buck doesn't stop here. There are so many sites in BRAF Kia fusion that there are so many sites on both the genes that the analysis is very, very laborious. So you have 5 different fusion variants on Kia BRAF only. And for fish, you have no consensus on cutoffs. In India, we have not been able to standardize that technique because the third signal sometimes gets obscured and sometimes there is artifactual loss of the third signal. And every third day you read a paper, there is new novel fusion variant. If if BRAF fusion eventually is critical for response to MAC blocking drugs, I need optimal assays to detect as many variations as possible. Who's going to give me that? Regarding B600E, works very well with IHC, but not your manual. Dear students, you need $500 crore of investment. You have to buy Ventana machine. That automated machine will only work with B600E. And if you think, sequencing is the gold standard, there is a paper which says that in gangliomas, actually, the efficiency of sequencing depends upon number of ganglion cells. If it is less, the reliability is poor. So what do I resort to? So they say in those cases you do allele specific PCR. So still I don't have the answer. What would be the gold standard? So many publications, you can't even see from the distance how many, but so many clinical trials under the way, but benefit of targeting BRAF in pediatric low-grade gliomas is yet unproven. And regarding BRAF inhibitors, V600E mutated primary neuroepithelial tumors also, the evidence is anecdotal. Now coming on to, why we are doing these molecular markers, because they are going to give us therapeutic decisions. So coming on to my last topic, that is biomarkers as therapeutically exploitable molecular targets. Few CNS tumors, only few. Can you see this blue line? I can hardly see. Only few CNS tumors have therapeutically exploitable molecular targets. And why? Because, we are trying to use these markers, even if I have to, get a suit stitched, I'll go to 10 tailors. But for treatment, we are using one size fits all. None of the biomarkers driven strategies has shown efficacy in clinical trials till date, and the patient survival remains poor. Why? Why is it so? A study has shown that when they have, in a 6% of, and this is the analysis of TCGA data, they have shown that in 6% of cases, they saw that different cells were showing different amplification. One is EGFR amplified, other one PDGFR, and third one is MET. And these different genetic changes resulted in different protein production, and we are giving one EGFR V3 mutant to all. How is it going to work? I don't know. And this is a beautiful paper. I would ask each and every resident to read it. Go home, read it. I can't discuss it. Glioblastomas, they vary in their molecular alterations not only in space but also in time. So if I have 5 biopsies, one will show PDGFR amplification, other will show gain, third will no change, fourth will no change. And in time also they keep on harboring different mutations. Where we are going to catch them, I don't know. Tumors are very smart. Your molecules are going to fail. So still, sir, dear Dr. Demling, we are still long way from having complete understanding of how cancer cells are driven, how they evolve over time, how they interact with host environment, how, last question, how they react to therapeutic intervention. I want answer to that, then only, otherwise demolecularize. Sir, my own domain is in threat and you are asking me to adopt these molecules. Why? You want me to, pathology diagnosis to become domain of subspecialty labs, either with academic or commercial people, and you want me to sit on the sidelines and watch? No. I won't do that. I have 2 opponents, not one. I can stop Sridhar by arguments, but I cannot win over Dr. Demling. But we can be proud that basic histological, histochemical and IHC stains continue to give us diagnostic, prognostic information till today, and they still remain at the forefront of research, and they have enormous impact on biology, cell biology and molecular biology. So, this thing. Do we need molecular markers for routine reporting? Please raise hands. No! We need to have, what we need to have is we need to have multiple centers. We should actually assess the real need. We have to formulate our own guidelines, we have to do budgeting, we have to build our own infrastructure, do training, teaching, and implicate only when required. We have to adopt our own. Why should we follow WHO? Why? We are the largest
We don't have to
country
see the
with
slides
so much
also, madam.
population. No. We will formulate our own guidelines. Dr. Chitra has, formulated these guidelines. She says histological classification first, followed by grade, molecular information. Then if I have the source, I will give integrated diagnosis. Why not? Last but not the least, don't go so near the tree that you lose the sight of the forest. It might be a good time to step back, take a breath, and try to remember what we are all here for. Not to display beautiful markers, but patient care. So, I would like to conclude that it is the experience of histopathologist which is prime and irreplaceable for correct interpretation of data. Thank you very much.
I'm sure you agree that her motion was absolutely powerful, and I don't know what the audience poll is. I'm not going to moderate this, but I want him to rebut, to give the final remarks on this. Oh,
My turn, madam.
little bit. I'm so
Madam,
sorry.
I am your great friend. I hope you have not joined hands with Sridhar.
The moderator goofed up a bit. She's going to rebut a little. Short one,
Yeah,
Vaishali.
short one. I had purposely hidden my conclusions. I would like to conclude that gold standard for pathological diagnosis should be careful morphological evaluation of a neoplasm. Sorry, sir, we cannot forget that we are a poor resource country. Your microscopic findings, if correlated with age, clinical manifestations, primary site of the tumor, and imaging studies, give you, a reasonably good answer. But if you don't get your answer only in those rare cases where specific diagnosis cannot be favored, I am saying if I can, be 100% with these two, why should I adopt molecular markers? If, the specific diagnosis cannot be reached based on histology and, then only we should resort to molecular studies. And I would just like to add a caution that tumors which are difficult to analyze on a microscope and you cannot get a definitive answer on a microscope are often, not always, are often the ones which lack consistent genetic abnormalities. Even Jesus said, you shall not put your Lord, your God to test. I would say, oh Lord, don't put me to test. But if you have to bring these molecular markers to my country, please make them available to all, affordable to all, above all, uniform, reliable, robust, and applicable to all. Then only I will accept them. I have two beautiful slides from today morning. One by Dr. Geeta, who said, it's been 10 years. We have not been able to standardize MIB in the sense there is lot of inter-observer, intra-observer variability. So how am I going to standardize all these gamut of molecular markers? And again, a beautiful slide by Dr. Demling which says that 50% of the cases diagnosed by a pathologist are correct. How can you say we are not correct? So it gives me, a small window, I have to be careful. I have to be sensitive to the needs of my country and then, make a judgment. So the whole onus lies on our professors. Dr. Sarkar is there, Dr. Radotra is there, Madam is there. I am not saying, don't take these molecular markers, take them with a pinch of salt. First assess them, let Dr. Demling assess them, then we will accept them. Let him, he made that antibody IDH is not working, then he said, I have already sold it.
We hope Professor Demling will certainly come back to our country again.
It is now time for us. Do you want me to surrender? Please tell me. Or you want to fight with me? Yes, my countrymen want to fight with me. And Sridhar, one has to be aggressive in life. Without being aggressive, you don't get any